Bismillahirrahmanirrahim. Thank you for the organizing committee, and thank you for my dear professor, the chairperson, and Professor Khalid for the nice introduction. This talk is about role of intervention radiology in management of GIT bleeding caused by malignant GIT tumors. As we said 5 minutes ago, GIT bleeding causes are bleeding ulcers, traumatic bleeding or iatrogenic bleeding, coagulopathy, bleeding cancers, and angiodysplasia. Bleeding cancer is not a common entity. However, it can be very life-threatening and difficult to manage as well. Diagnosis is usually done by endoscopy in case of upper GIT tumors and colonoscopy in lower GIT tumors, and CT angiography. CT angiography is very crucial for us intervention radiologists to detect the bleeding arteries and help and guide us to do our embolization. Multi-slice CT is a very accurate and sensitive modality to detect bleeding. It can detect bleeding rates as low as 0.2 millimeter of blood per minute. Also, the delayed acquisitions are very beneficial to detect slow bleeders and intermittent bleeding, as in this angiodysplasia. When embolization is required, it is more selective and quicker and less radiation and contrast dose to the patient because we know where are we going and which is the bleeding artery. We'll go through a quick case presentation. One is a gastric bleeding, another one is a small bowel, and the third one is a large bowel bleeding, all caused by GIT tumors. First case is a 30-year-old male patient with history of inoperable gastric cancer, presented with fresh hematemesis. He had multiple endoscopy sessions which failed to control the gastric bleeding. So the patient was referred to us to control his gastric bleeding. This is our angiography. This is the catheter, the Cobra catheter within the celiac axis, and then goes through this catheter, a microcatheter, into the left gastric artery. The angiogram shows neovascularity and abnormal vascularity within the gastric mucosa, which is the tumor vascularity which is causing the bleeding. And the aim of our embolization is to stop this bleeding. We used particles, polyvinyl alcohol particles. And this is the image after our embolization. And as you can see, there is embolizing material within the vessels that needed embolization. And you can't see any abnormal vascularity anymore. Our second case is a male patient who is 64 years old with a known GIST tumor, a gastrointestinal stromal tumor with multiple liver mets. Patient presented with severe melena and severe anemia, and the patient can't start his chemotherapy because of the anemia. So he was referred to us by our colleague oncologists for control of bleeding. This is the CT angiography. I hope we can run it. Okay, so this is the CT angiography. You can see the liver mets, hypervascular liver mets everywhere. All these are liver. These are the liver mets. I can't point. But you can see the liver mets, and then comes the tumor. This is the tumor, the GIST tumor. All this is hypervascular tumor causing the bleeding. And you can see it's occupying most of the abdomen, the small bowel. This is a coronal reconstructed image of the CT, and as you can see, this is the liver mets there, and you can see the stromal tumor with the very high vascularity. And our next step is to embolize this tumor to control the bleeding. ممكن نرجع بقى pointer. So this is our angiography. And as you can see, this is the hypervascular tumor vessels, all these vascularity. Again, this is our microcatheter. And you can see the tumor vascularity there. It's multiple, of course, these are multiple arteries, and we went super selectively into each one of them. And again, we embolized using particles. Again, you can see the abnormal vascularity there. So these are the GIST tumor before embolization. This is the GIST tumor after embolization. Sphenomesenteric artery, yes. So this is the sphenomesenteric artery after embolization. So if we compare this to that, we can see that this is a very well control of the abnormal vascularity within the tumor. Again, the patient had other branches from the celiac artery as well. So the GDA, the gastroduodenal artery. So we went into the celiac artery as well, and the gastroduodenal artery. You can see the. I'll try to stop it there. It's up to you, chairperson. اتفضل يا فندم. اتفضل.
Navigation of the sphenomesenteric, is it as the celiac or في فرق في صعوبة أكتر؟
لا ما فيش صعوبة يعني celiac ده sphenomesenteric and the celiac arteries are big arteries and you can easily get into them and then you go through their branches using a microcatheter, so it's not a difficult manipulation. So as we can see here, this is the celiac, this is the hepatic artery, this is the GDA, the gastroduodenal artery, and the gastroduodenal artery is also giving branches to the abnormal, to the tumor bed as well. So again, we went in, this is the image before, and this is the image after, and we did embolization of the one of the branches of the GDA, the gastroduodenal artery.
In one setting, all that?
This is all in one setting, yes. And of course, you can see there is hydronephrosis on the right side because the tumor is compressing the ureters. So this is hydronephrosis within the right kidney. Our third and last case is a 34-year-old male patient with history of inoperable cancer sigmoid colon, presented to the emergency department in the University Hospital, Alexandria University Hospital, shocked. Inoperable because of his shock stage. Vascular surgeons didn't want to intervene, so he was referred to us. This case was done 1 a.m. in the morning in our unit in the radiology department. This is the CT. This is the CT image, and you can see that this is contrast extravasation within the pelvis. The patient has sigmoid colon and he has double J catheters within the bladder. This is our angiography, and you can see the extravasation coming from the left external iliac artery. The tumor, the sigmoid cancer, is invading the external iliac artery and causing a rent in the artery, a hole in the artery, يعني خارم الارتري عمل فيه فتحة يعني. And this is all contrast pooling outside the artery. We went from the right side to the left side, and you can see this is the colostomy bag. So we went from the right up into the aorta and down into the external iliac artery. This is all contrast extravasating through the hole in the artery into the pelvis. A very life-threatening patient was intubated already. So we decided to put a covered stent in, and a covered stent or a stent graft is a metallic stent which is covered by fabric, زي قماش يعني, to seal the hole and meanwhile maintain the flow in the artery, because this is the external iliac artery, which is the supply for the left leg. You can't just occlude the artery, otherwise the patient will have an amputation of his left leg. So this is the covered stent. Of course, you can't see the fabric, but you can see the metal. So this is the image after we put our covered stent. You can see the flow is maintained within the artery and there is no contrast extravasating outside. This is the pre-image. You can see the contrast. This is the reconstructed CT, which he had a few days later on. You can see our covered stent. No contrast is extravasating. These are the double J catheters because of his previous surgery. And that's it. Thank you very much.